Nevin Chinnan. He is currently attached at ICU specialist at various hospitals in Australia.
Good afternoon, everyone. A warm welcome after the lunch break. And I must admit that we kind of fast-tracked the whole talk also. So the topic is fast-tracking the ventilated intensive care patient. So for the talk, I don't have any financial disclosures to make. Obviously, there's a bit of personal bias that I believe that patients in intensive care do well if they can get out of there early as possible. The longest stays are kind of a surrogate marker of poor outcomes and even death. So the fundamental question is, why do we ventilate our patients? We had a brief mention about this in yesterday's workshop. The fundamental reasons remain the same. Either you have a primary lung problem, and for that you get ventilated to improve your oxygenation or to improve the carbon dioxide elimination. And there are also patients who will have normal set of lungs who would need ventilation because they have an endotracheal tube in place. This could be because they have an upper airway obstruction which needs to be bypassed, or their level of consciousness is low enough they can't protect their airways, or to facilitate surgical procedures in a paralyzed patient. Now, the big question, the elephant in the room, is that do we believe that ventilation is curative? Does it make the patients better by itself? The short answer is no. The role of ventilation in intensive care at best is supportive. It has the potential to further damage an injured lung and has the potential also to damage normal lungs. So it makes perfect sense to fast-track a ventilated patient. So the proof of concept for fast-tracking of intensive care patients come from the post-cardiac surgery. Historically, they all used to be ventilated overnight because they all got a ton of opioids, because that is the golden rule with regard to your cardiac stability or hemodynamic stability. Then in early 90s, we started having a revisit of the whole concept. People developed protocolized care, which is basically time-based evaluation of laboratory and radiological workup. They set predefined hemodynamic goals, which allowed the nurses to titrate vasopressors. You did cardiac output monitoring and then subsequently titrated your inotropes of choice. There was also a weaning regime in place, and that is a very simplified regime which did not need an ICU specialist standing at the bedside to get it done. Basically, when the patient is warm, you try to wake them up, effectively turning off all the sedation, and then wean them off the ventilation. And the goal being to extubate them in 4 to 6 hours. This is a physician-led but nurse-driven protocol. So it had its benefits, you know. It allowed the physician to look after the sickest of the lot, so you could actually improve your productivity. You know, the single doctor could actually look after like 5 to 10 patients post-cardiac surgery. They were able to generate the same kind of outcomes for the patient. They could shorten the intensive care stay. There was better utilization of resources, so there was no backlog of patients waiting for an ICU bed to get the surgery done. There was cost savings. Whether it translated to cost savings for the patient depends which health system you work. You know, if you believe that staying longer in intensive care generates more money for the hospital, obviously this is not the right model. It is not a perfect model, obviously. There were major challenges, like if a patient was an outlier in the system, there is always potential to harm. If a presumed pericardial tamponade was missed, you may find that people will keep on increasing the hemodynamic support and miss it for an extended period of time because they're trying to force a patient who's not inside the protocol into it and can potentially cause harm. There's also a theoretical risk of over-investigating. You know, you're going to send hourly blood gases, you're going to do more x-rays than needed, clinically indicated, because it is more like a industrial production line. If you look at the data which has been published about fast tracking and how safe it is in post-cardiac surgery setup, there's no proven risk of increased morbidity or mortality. The reintubation rates remain the same. Major cardiovascular outcomes like stroke or MI, they remain the same. There was no increased risk of rebleeding and the patients going back to theater. There was definitely shorter intensive care stay. Interestingly, the big outcome of the length of stay in hospital, whether you fast track or not, could not be demonstrated to be any different. There's also some caution. You know, you can't jump in and say every patient who comes through the door into your cardiac surgery unit is going to be fast-tracked. So if you've got severe elevated function, you're on lots of inotropes, or mechanical assist like the IABP, or you have a patient who has an emergency surgery, or significant renal failure likely to require dialysis, most studies have excluded them, and I don't think it is standard of care to put them into the fast-track pathway. Now, the same concept has been now extended to other homogeneous ICU populations like post-liver transplant in neurointensive care like stroke thrombolysis or coilings in the unusual patients, or even in colorectal surgeries as a part of the early recovery after surgery pathway. My task today is not to elaborate on this well-established practice in cardiac surgery or homogeneous population. We're trying to extrapolate the best practices and evidence available to apply it in the heterogeneous mixed ICU population of medical ICU, emergency, surgical, and trauma patients, the goal being to facilitate early weaning and liberation from mechanical ventilation and shorten the overall length of stay in intensive care as well as return to home at the earliest timing. The first rule, do the right thing. What we mean by that is that you should always ensure that the primary reason why you've intubated your patient has been reversed. So, for example, if your patient was intubated for pneumonia, you should wait for clinical as well as closer to a radiological resolution. If it's acute abdomen, the pus has to be drained, either surgically or radiologically, or the primary problem is addressed. If it's upper airway obstruction, it needs to be relieved before you attempt to fast-track your patient. Now, sedation and analgesia, a very important part of tube tolerance in intensive care. It has also been attributed for possible extended stays in intensive care. Okay. We must acknowledge both are different. Sedation, the goal of sedation in intensive care is to allow the patient to tolerate the endotracheal tube and provide some degree of anxiolysis in a strange environment among strange people looking after them. Analgesia, the goal is slightly different. If you're a post-surgical patient, it provides enough pain relief so the patient can breathe properly. Also provide enough comfort so they're less likely to get agitated down the track. Now, people use different, either they take a guesstimate of what this patient will need and start on a particular infusion or a drug regime, but it's important to recognize that the requirement changes over time. And this is very important. Each day is a new day for a patient. You know, the first day the requirements may be much higher, then would the most patients, as they're improving, their requirements come down, or you are obliged to cut down on the requirements of sedation as well as analgesic and reassess your patient. If those patients are getting worse, or like if they have gone into ARDS, I think we'll go in the subsequent slides on that, you may require increasing doses of sedation. So that's an important concept. Next thing is that even for the same pathology, different patients will have different requirements. If a patient is of chronic pain, you know, you may say that I don't think I usually use 10 milligrams an hour of morphine in an intensive care patient. But if the patient has got a history of IV drug use or chronic pain and a lot of opioids, you may be using much, much higher doses. So it's all about titrating into the patient's end point of sedation as well as analgesic requirements. Choice of drugs, no great data to say that it has morbidity, significant morbidity or mortality benefit. The most common combinations are an opioid in combination with a GABA mimetic, either midazolam or propofol. The new kid on the block is dexmedetomidine. The main thing to remember about dexmedetomidine is that the data is still inconclusive. We are still learning about the drug, about its where does it stay in the current intensive care practice. It's been increasingly used. We know that there is a trend towards benefit in keeping the patients cooperative, conscious, and able to communicate pain. There is less chances of delirium in patients treated or managed for sedation with dexmedetomidine. However, the caution is on patients, especially on higher doses, when as a single agent, if it's not working and you start going doses above 1 mics per kg per hour, there's a risk of sudden bradycardia and sudden cardiac arrest, especially when you combine with drugs like vagomimetic drugs like propofol or larger doses of fentanyl, and if they've got renal impairment. So the other concept which I want to discuss is the role of duration, or rather interruption of sedation. There was a paper in New England Journal in 2000 which brought about a lot of interest in the medical ICU world that if you interrupt sedation, you will have a shorter length of stay. It's kind of true in the medical subpopulation. It cannot be extrapolated to the surgical world or surgical intensive care, especially neurointensive care. It's probably one of the worst things you can do to your patient. Come in the morning and turn off all sedation, and the patient tries to wake up. And the reason for intubation, leaving him intubated, was for neuroprotection and keeping the ICPs. And I understand a lot of people here in this audience work in units which don't have access to intracranial pressure monitoring on a regular basis. So their ICP is going to go very high. So it's a no-go zone to say we do a daily interruption. Same applies to patients with ARDS. If you're paralyzing your patient or you intend to keep them deeply sedated, the last thing you want them is to wake up and start triggering big breaths, and all your 6 mL per kilo tidal volume goes through the window. Okay? It may be an option when you think your patient in intensive care in the recovery phase of illness. So that's a very important concept. Unfortunately, the authors of the paper didn't really stress it, that if you see any critical care patient, broadly they fall into two groups. One is in the acutely sick stage where their physiology is significantly deranged, and the next stage is the physiology has been restored and you're expecting them to gradually improve from the illness and also from all the gadgets as well as sedation you've poured into them. So that's the phase where your daily interruption, all those things may have a role. The other factor which we need to take into account is presence of delirium. As we have more and more elderly patients coming to intensive care, it's much more of a common problem. And delirium does not equal to lack of sedation. Delirium is not managed by increasing the dose of sedation. So you obviously want to exclude patient discomfort, pain, and all those things. When you address your delirium, you exclude your metabolic causes or primary neurological reasons for that. And once all those are excluded, the management is going to be using of drugs like haloperidol, which fall into the category of antipsychotics, but that's what we try, or any of the similar class of drugs. Okay? And the only exception is patients with alcohol withdrawal where benzos are preferred over them. Dexmedetomidine, as previously mentioned, has more of a prophylactic role. Whether it's got in established delirium, it's still debatable. Now, what about ventilation strategies? Do the modes really make a difference? There is no major published data to support that a particular mode would shorten your intensive care stay. This is excluding all the industry-supported small trials of 30 patients or 100 patients. So we would assume that whatever mode you use does not make a big difference in terms of patient getting out of ICU quicker. Another area of interest is spontaneous breathing trials. So it is not a surrogate to say whether the patient is, it's more of a surrogate of, if you do a spontaneous breathing trial, it's more of a surrogate of telling whether the patient is ready for extubation, which is different rather than telling that patient's lungs is getting better. So you don't want to be doing spontaneous breathing trials in the really sick patients. The reason being, it will generate high transpulmonary pressures. You may leave someone on pressure support of 8. You would say that this patient would take only smaller tidal volume. That's a minimal pressure support, which everyone presumably should have, having a tube connected to their lungs. But the reality is that the set pressure is not what the patient's lungs get. They generate huge interpleural pressures, especially when you're ventilating patients with your arsenate protocol or low tidal volumes and allowing for carbon dioxide to build up, having permissive hypercapnia. It's a very strong medullary stimulant. Unless the patient is very, very deeply sedated or paralyzed, they are going to generate huge tidal volumes, and you would not be able to regulate your tidal volumes taken in by the patient. So there is also data to say that if you paralyze your patients who have established ARDS early in their illness, it even translates into improved survival. For patients on ECMO, it's just more of a passing comment that, again, if they're on the recovery phase, it may be reasonable to try them on spontaneous breaths. The main advantage of trying all this spontaneous breathing in ventilated patients is that it can minimize diaphragmatic wasting, less chances of developing critical illness, myopathy or polyneuropathy. Now, a major trend in intensive care is increasing use of non-invasive ventilation. And what is its role in fast tracking? The main proven subclass of patients is patients who are morbidly obese, COPD patients, or even the occasional refractory asthma patients whose spasm was settling down and you want them off the vent. High flow nasal prongs is also coming up in a big way in the post-surgical setting, so I wouldn't be surprised if they come as a part of the fast-tracking strategy as we gather more and more published evidence on that. Now, there's a difference where you put patients on non-invasive ventilation as a prophylactic thing. You're extubating onto BiPAP or for your morbidly obese patient. They're likely to do well. But when you're putting a patient on NIV as a rescue for presumably failed extubation, the outcome data suggests that those patients are going to do very poorly. Rather, there's an increased risk of death. So if you think that you're failed extubation, don't waste time. At least that's what the data tells us, that don't force NIV on them. You may be better off intubating them early. Tracheostomy, that's the other way we can probably try to get the patients out of intensive care. Most of the data come from the traumatic brain injury world, and we have seen the pendulum swing both ways. The general consensus is that early tracheostomy is beneficial in traumatic brain injury, but you should read the fine print. When they say it's beneficial, it's about leaving intensive care. It doesn't translate into improved Glasgow outcome scores. It does not translate into patients leaving even the hospital. And this trial even shows that there is an increased hospital mortality. So I take this as a kind of surrogate indicator that when we fast track, we must be cautious. Are we really outsourcing a problem in intensive care to step-down units? And we know that the care in step-down units is going to be much more compromised in intensive care. So in some setups, it may even translate into increased hospital mortality.
Sir, please conclude in 2 minutes.
Yep. So the broader issues for... So tracheostomy timing, this is what I'm more interested in. Like, you should look into the timing of the broader concept. Is the patient safe to have tracheostomy? Can you actually have a safe cervical spine to allow for your neck manipulation? Always think about early tracheostomy in a patient who is unstable from an intracranial pressure point of view. You're going to force hypoventilation into them. The head end is not going to be elevated when the procedure is being done. So all these things are going to actually harm the patient. So all those data has to be interpreted with caution. Then same thing with patients in ARDS. Don't try to rush to do a tracheostomy in a patient with ARDS when they're on high PEEP. There's an increased risk of derecruitment, desaturations, much more difficult to operate on them, and you will get extensive subcutaneous emphysema, and it doesn't make any sense. You're attempting to leave these patients paralyzed, deeply sedated, so what are you going to gain by doing a surgical procedure? Obviously, there are benefits to early tracheostomy, like patients with normal lungs, when it was done for bypassing the upper airway, or when they have normal lungs with a primary musculoskeletal problem, they would definitely benefit, and in the recovery phase of critical illness. Now, I find the data quite fascinating. Like, we have to accept the fact that some patients in intensive care are going to die. The 90-day mortality in ARDS ranges between 1 out of 3 or 1 out of 2 patients. Septic shock from the early goal-directed recent studies, they show it's around 20 to 30% again. So, and the unfortunate part is that there is no predictive scoring to say that this patient is going to die. If you have 3 patients coming with septic shock, even if their hemodynamic parameters, everything look the same, there's no way of telling that this patient is going to die, whether you do your Apache, SOFA, all those things. In a given patient, it's much harder. And when they assess, they find that clinicians are better at predicting who is going to be the non-survivor. There's something like your clinical cues. You know that he is likely to get into trouble. And even worse is that sometimes we know that the patients are less likely to survive, and we still continue to treat them. I would say that it's better to be sometimes more pragmatic, more compassionate to the family, and learn to acknowledge and accept treatment failure. So why I'm talking about the non-survivor data in a fast-tracking thing is that eventually there are only 2 ways a patient is going to leave ICU, dead or alive. So we cannot say that we would completely ignore that outcome. To summarize, fast-tracking philosophy works on addressing the primary pathology first. We must titrate the sedation and analgesic for the patient on a day-to-day basis and on an individual basis. We must recognize delirium as a separate entity and address it appropriately. Individualized ventilation strategy, no modes are going to do magic. We must ascertain the NIV role in each patient subgroup separately, and think about the timing of tracheostomy in a broader concept rather than just rushing to do a tracheostomy to get the patient out of intensive care. And at times, prudent to acknowledge futility of ongoing intensive care. Thank you very much.
I think we will move on. I think, as I said, it's a difficult topic, I think. And when I gave you this topic, I think you weren't sure what we're going to discuss looks like, isn't it?
We can obviously discuss on site.
Yeah, we'll discuss it on rest on things.
Thanks.
Thanks
Thank
very
you,
much,
Dr.
Nevin.
Nevin. Our next topic is